Part of what we do in the practice is pharmacologic management, and sometimes it's complex polypharmacologic management. And that means because the patient's pain needs, they're on a variety of medications, and usually the medications each work through a different mechanism of action. So for example, you may use something directly to treat the pain, you may use another medication to treat inflammation. They may also require something for muscle relaxation. A patient may have their mood being affected because of the ravages of chronic pain that some patients have, so you may need an antidepressant. A patient may have nerve pain as a component of their pain, in which case we have agents that are very selective for nerve pain. Some of the, for example, anti-seizure agents work very well for nerve pain. In addition, there's topical agents that can be useful. So the host of medications in our armamentarium, and the goal is to use the risk-benefit ratio for each of these in order to optimize the patient's pain relief while limiting the side effects. Other patients don't have adequate relief from only medications, and you end up combining that within a treatment program that also includes, for example, selective steroid injections for the main source of the pain, in addition to chronic pain management with medication use for aspects of their pain that are more chronic and continuous. We try to, again, use a risk-benefit ratio with any medication we use, and that includes, for example, opiate medication. We try to minimize the use of opiates. Opiates are outstanding pain relievers, but they're always used with a lot of thoughtfulness involved. If a patient has metastatic cancer, we tend to pull out the stops more as far as what medications are available, and we have less concern of long-term consequences. In a patient that is relatively young and has chronic post-operative pain, but they're going to have to live with this for a long period of time, we tend to either minimize or not use opiates because we're looking at a long-term strategy, and we may not choose to use opiates in the long term. So I mentioned some of the other medications we have available. We have a lot of tools available to us other than pure opiate pain medications, and we try to optimize that therapy prior to using or in addition to a lower dose of opiate treatment.